Where do we stand? Dr. Mohammad.
Thanks. So keratoconus is a condition that affects roughly 1 in 2,000 people. It's a bilateral, non-inflammatory, progressive condition associated with corneal thinning, irregular stigmatism, scarring, and myopia. So in terms of our treatment algorithm for keratoconus, rigid gas permeable contact lenses really are the mainstay of our treatment. Patients with mild keratoconus may do well with glasses or soft contact lenses. Intacs, which we'll hear about in a little bit, can play a role for some patients, and then patients with more advanced disease may go on to require corneal transplantation. So now to understand where crosslinking fits, it's important to understand the pathogenesis of keratoconus. In keratoconus, the corneas have been shown to have decreased biomechanical strength associated with a decreased number of collagen crosslinks. Now, interestingly, keratoconus is thought to be less common in conditions associated with increased crosslinking, like smoking and diabetics. In fact, it's theorized that patients with diabetes with a higher glucose level in contact with natural UV light have a natural cross-linking process that takes place, which may lead to some aging changes in their skin, but may also protect their corneas. Now, what is collagen cross-linking? It's a photopolymerization process associated with irradiation with UV light in the presence of a photosensitizer, and riboflavin is the photosensitizer. It also increases the absorption of ultraviolet light, and there's not been shown to be any cytotoxic effects on keratocytes with this condition. So how does it work? So riboflavin is stimulated by ultraviolet A light, leading to the release of excited oxygen, which leads to covalent bond formation. So you go from a state with less cross-linking to increased cross-linking following treatment. And how does that work on the cornea? Well, it's been shown to increase the biomechanical strength by over 300%, a 320% increase in corneal rigidity. It's been found to stabilize, to stop or slow the progression of keratoconus, and it may in fact lead to regression or improvement in vision. Now, cross-linking is not new in medicine. There are many examples. A few include in dentistry. Dentists use ultraviolet A light to harden dental fillings. Heart valves are subjected to cross-linking to improve stability and mechanical properties. And in dermatology, the dermal fillers are cross-linked as well. In ophthalmology, the theory behind cross-linking was proposed about 35 years ago by Siegel at UCSF. He presented theoretical evidence of cross-linking, but it wasn't for another 25 years in the late 90s, 97, 98, that this was clinically applied in Germany at the University of Dresden. In 2003, human studies began, and in 2006, it was approved by all 25 European Union nations. In 2008, it was approved in Canada, and that's when we started our FDA trials. A little over a year ago, Avedro, which is a company that makes riboflavin, was granted orphan drug status by the FDA for the treatment of keratoconus. Orphan drugs promote the development of new therapies for rare, uncommon diseases or disorders affecting less than 200,000 people in the United States. So that's the criteria through which Avedro did receive FDA approval. The UVA light source has not received approval yet. So just to go over some of the results that we have, and much of our data comes from abroad, but I will discuss some of our FDA data as well. To begin with, most of our early work comes from Dresden, and they looked at 241 eyes with progressive keratoconus. Now, most of the studies do state that they looked at progressive keratoconus, but they don't often define what progressive keratoconus is. This study did, and they defined it as an increase in Kmax more than 1 diopter in 1 year, a subjective decrease in vision, and more than 1 new contact lens fit in a 2-year period. And they found a significant decrease in steepening with keratoconus, 2.68 diopters in the first year, and much more significant by year 3, but the numbers really dropped off. They went from 241 patients to 33 patients, but a very significant, almost 5 diopter decrease in astigmatism. They also noticed improvement in best corrected vision in over half of patients. 2 patients did have progression and underwent retreatment, and unfortunately there was no control group in this study. The Siena eye cross study was another very large study, over 300 patients, and they found a mean decrease in mean K of 2 diopters, with an increase in best-corrected vision of almost 2 Snellen lines in their patients. And they did have a control group, and they found that 65% of fellow eyes progressed, about 1.5 diopters over a 2-year period. And here's a nice graph from the study, and time 0 is when the first eye was cross-linked. We can see before that, both the treated eye as well as the fellow eye were progressing. Once the treated eye was treated, you had a regression of 2 diopters at 1-year time period. The fellow eye continued to progress, and then at 2 years they were offered the treatment, at which time a similar regression was noted. The same group also looked at different age groups and cross-linking in a pediatric population, an intermediate, which they defined as 19 to 26 years of age, and an adult population. They found all age groups improved, but the pediatric patient population did best, with intermediate doing similar. And they proposed cross-linking as a first choice for patients with progressive keratoconus for patients less than 18 years of age and patients in the intermediate group, 19 to 26 years of age. So I mentioned the FDA trials here in America. Peter Hirsch from New Jersey did publish his results. He had 71 eyes, 49 of which were keratoconus. And he found that almost 45 patients with keratoconus gained 1 Snellen line at 1 year, 1 Snellen line or more at 1 year. One patient lost 2 Snellen lines. That was a patient with post-LASIK ectasia, not keratoconus. The maximum K decreased by almost 2 diopters, 1.7 diopters with all the patients, and 2 diopters in keratoconus patients. He proposed that keratoconus patients likely respond better than post-LASIK ectasia to cross-linking. He also had a control group and compared best-corrected vision as well as Kmax at 3 months and 12 years following, 3 months and 12 months following treatment. With both parameters, there was no difference at 3 months, but there was a statistical significant difference, improvement in the cross-link patients at 1 year in both best-corrected vision and maximum K. And then the last study I'm going to discuss comes from France, and they looked at 142 patients with progressive keratoconus at 6 months and 12 months. A majority of patients had stabilization or improvement in both vision and topography. But the reason I want to discuss this is because they were more detailed on their complications. 5 eyes had loss of vision, 3 related to haze, 1 related to a corneal burn from ultraviolet A light. Now, they're not very detailed on what the specifics were about the ultraviolet A light and what led to the corneal burn. 1 patient with corneal edema. 5 patients had haze without loss of vision, and 4 patients went on to require a DALK, 2 because of progression, 1 with a corneal opacity related to that corneal burn, and 1 patient with poor vision in spite of stabilization. So there are obvious complications, as with any procedure. Corneal edema is one that's concerning. We know that corneal edema is more common with thinner corneas. This procedure is not recommended for a corneal with a corneal thickness less than 375 to 400 microns. There's some thought that applying hypotonic riboflavin may help increase corneal thickness, but still you want to be very concerned about corneal edema. Corneal haze can be a concern. Infectious keratitis can be a concern. Herpes simplex, bacterial, even fungal. Corneal burns, as I mentioned from the French study, and treatment failures. Who are more likely to fall in that category? Patients older than 35 years of age, patients with really good vision, 20/25 or better, and patients with more advanced keratoconus, maximum K greater than 58 diopters. And then there are also definite contraindications to this procedure. I mentioned corneal thickness should be above about 375 microns, severe dry eyes, pregnancy. This is the first time that we and the cornea department are administering pregnancy tests before our patients. That is a contraindication. Corneal scarring, herpes simplex, inability to maintain a steady gaze or nystagmus. Okay, so if we look at the body of literature, how well does this procedure work? Well, based on the different studies that I presented, 87 to 100% of patients seem to stabilize. Now, that's a little bit tricky because the enrollment criteria should be progression, but many of the studies did not define progression for their patients. So keratoconus eventually does stabilize in all patients, but it is really the patients who are progressing that we really want to apply this treatment for. Improvement in vision in somewhere between 45 to 70% of patients. Now, this is not dramatic. You're not going to take a patient who is wearing rigid gas-permeable contact lenses and give them good uncorrected vision, but it does look like it can improve vision by 1 to 2 Snellen lines. The patients are still going to be dependent on their glasses or contact lenses, and therefore it's really important that patients have very appropriate expectations. The goal is to stabilize the cornea, not to give them good uncorrected vision. So now if we return back to one of our initial slides on the treatment of keratoconus, where does cross-linking fit? And I think it fits in the early treatment for keratoconus in patients who are wearing glasses or soft contact lenses, or the more mild, moderate patients who are wearing rigid gas-permeable contact lenses. The key is it's the younger patients who are showing signs of progression who may benefit from this treatment. Now, the reason we're really excited about this is because we are involved in the Avedro Study. This is a phase 3 clinical trial. It's a multi-center randomized controlled study that's evaluating the safety and efficacy of the KXL system, which is their ultraviolet A light source, with Vibex, which is the riboflavin, for cross-linking in keratoconus and post-LASIK ectasia. The primary efficacy criteria that we're looking at is mean change in Kmax at 6 months and 12 months. And our patients are being randomized into 3 different treatment groups with a different time and strength of ultraviolet radiation, but same total power, 7.2 joules per centimeter squared. Now, this is a little bit different from the Dresden protocol, which had a longer duration of ultraviolet A light exposure, 30 minutes, but less power, 5.4 joules per centimeter squared. So this is the KXL system, this is the light source, and this is the riboflavin. Okay, so how does it work? Now, we are doing an epithelial off treatment. All of our patients require an epitheliolectomy. We remove the central 9 millimeter epithelium, and then riboflavin drops are applied. Drops are applied every 2 minutes for a 20-minute time period. And once the riboflavin has progressed through the entire extent of the cornea, the ultraviolet A light is applied for a duration anywhere from 2 minutes 40 seconds to 8 minutes, depending on which group they're randomized into. There are other variations in the treatment. The Dresden protocol I mentioned is one of the initial protocols for cross-linking. Transepithelial cross-linking has been proposed. It does not look like it's as effective as epithelial off cross-linking, but obviously there are benefits in terms of pain control, healing, getting patients back into their contact lenses. Femtosecond laser-created pockets have also been proposed, creating a pocket, applying riboflavin into that pocket, allowing it to progress through the corneal stroma, and then applying treatment is a certain possibility. Pulsed ultraviolet light as opposed to the constant light that we're using. And then combined procedures. Cross-linking with Intacs is commonly performed. Cross-linking with PRK has been proposed. Cross-linking with phakic IOLs for keratoconus patients. And then cross-linking for other indications such as infectious keratitis and corneal edema. So I'm going to end with, who is a good candidate? Who should we really target this treatment for? Patients with documented progression in keratoconus, whether that's based on vision, topography, keratometry, or refraction. The younger patients do better. They're the patients who are progressing. Patients with mild or moderate keratoconus without significant scarring. Corneal thickness greater than 375 microns because of the risk of corneal edema. And patients without any other contraindications such as herpes simplex, dry eyes, and autoimmune disorders. Thank you.